Everyone, thanks for joining us today. My name is Gregg Masters. I am the publisher of a blog called ACO Watch, and I've been in the healthcare industry about 3+ decades, so I go back a ways. And I want to thank Chris Sepper for the invite to moderate the panel today. We've got a great panel, so I'm going to just say a few remarks and then we'll get them out here. Simply want to make note of the fact that the sentiment index on ACOs, when they first started, particularly in the rules development process, was fairly skeptical. There were the evangelists who were saying, this is the triple aim, this is the means to the triple aim. And there were those, too little, too late, these are HMOs light, they'll never work, they're dead on arrival. So that sentiment, sensing, if you will, the prevailing sentiment towards ACOs, the needles moved somewhat to the right. Those who were writing skeptical comments, particularly in the rules process, had some of their concerns addressed regarding disproportionate risk and so forth. And they're starting to sense now that you have to make a claim to get into this notice of the class of 2014 closed May 31st. So there's sort of a lockout going. So there's a sense you better get on this train because it seems to be leaving town. So there's a lot of enthusiasm. So the cornerstone in many of the differentiation for competitive purposes and longer term viability comes down to this patient engagement idea. So bear with me here. I thought I would just set some context here and we'll go right to the panel. So this is a piece that was published on betterpatientengagement.com titled, "The Path to Increased Patient Engagement Lies in the Definition." One significant challenge with improving patient engagement lies in the lack of a standard and correct definition of the term patient engagement. A 2012 NEHIC survey found the following responses when asked, how do you most likely describe patient engagement? 64% stated patient uses educational materials and online resources to learn about better health of their own health condition. 58.7% patient uses tools and resources to manage his or her medical record and other health data. 41% patient feels comfortable challenging doctor when something doesn't seem right or when explanations are not clear. 38% patient feels comfortable discussing health issues and questions with a doctor or nurse face-to-face. And 36% patient communicates with doctor about changes in health status in a timely way. So the last comment is there are three trends converging that makes this especially important and timely now. One is the health reform, the Affordable Care Act, predated by the era and the high-tech provisions for meaningful use. Secondly is the convergence of this patient voice, and one example of which is this beautiful woman over here, Regina Holiday, who's busily painting and rendering her vision of the conference. And the third is the technology and the convergence, social media, EMHS, the explosion of digital health applications. These are colliding, mega trends that are colliding to generate both the accountable care frame of reference as well as the medium and engagement for the voices that are going to come and make that happen. So let's get the panel out and we'll go right to it. So joining me today, we're going to get granular, is Libby Webb, Director, Product Management for athenahealth, Lanie Abbott, Senior Communications and Outreach Coordinator from EMHS Population Health Management, and to my left, Colin Ward, EMHS, Executive Director of the Greater Baltimore Health Alliance. So who would like to go first? How about Colin?
Sure. I'll preface my comments by saying that my treadmill at home hasn't been plugged in many months. I ate a tasty cake for breakfast, and the next piece of fruit I eat will be the first this year. So I individually may not be fully engaged, but I can talk about organizationally what we're doing to try and work with patients and providers to help them really become more a partnership in maintaining health. So we are a shared savings program, Medicare program. We started July 1st of 2012. We have really found this combination of healthcare IT, as well as the Affordable Care Act and individual changes within our practices through patient-centered medical home and transfer med to really be this fertile ground for activating patients and providers as well, so that we see a lot more of the patients from the patient side. We have a portal where they can access information, clinical lab information, and some test results, imaging and things of that nature that they're able to access. And we thought, with the EMR that we're using now and having patients on this portal, it will foster a lot more electronic conversations. And what we found was the patients were very engaged, to the point that our telephone activity actually increased because they were aware of things, the patients, that they hadn't been aware of previously. And so we have begun to work with patients from activating them on the portal side. Obviously, we have care management resources, and so we have embedded folks that you can literally walk down the hall with and say, Mr. Ward, you've been recently diagnosed with diabetes. Here's how we can help. And you set this standard for communicating with patients, not in those 15-minute doctor's visits, that you can maintain this relationship and really get them to be more involved with keeping track of what their morning blood sugar looks like, or how their weight may have changed over the course of weeks or months. So that's really where we are. We have about 100 primary care providers. Many of them are in patient-centered medical homes. We're working closely with our hospital, the Greater Baltimore Medical Center, to coordinate the activities so that we know about patients and they know to tell us when they potentially have a procedure that's upcoming, or we know that they've come through the emergency department, so that we can schedule them back. And really what we're trying to do is create sort of a known value to the patient, that if the things that we're doing to engage them will benefit them in some way, they're much more likely to join us in that partnership.
So let me ask you this, was this a pre-existing entity before the Accountable Care organization was formed, or what was the genesis there?
So we have a large employed physician practice, and we created a new legal entity to participate in the ACO that also allowed independent community practices to participate. So we have an alliance of another 20 providers that otherwise wouldn't be able to participate in this activity that we have grouped together to form the ACO.
So talk about the process whereby you came to terms with this concept of patient engagement. Talk about how you defined it. How'd you frame it?
Right, so a lot of that came through the patient-centered medical home process, and really beginning to look about where does the patient benefit the most in the care, where can they do the best. So we often talk about compliance, and the patients aren't compliant. We tell them what to do. I can tell them to stop smoking till I'm blue in the face, and they aren't compliant. But there are other portions of compliance that we, on the provider side, don't make it easy for them. So when they're discharged from a hospital, we may have tweaked a few of their medications, changed the dose, changed the frequency, and sent them back out. So we really started to think about what is the best way to help the patient maintain their health without a lot of extra interaction, as well as begin to educate patients more about how we can help them. We have, Maryland has an HIE through CRISP is what it's called, and we have a patient notification system where we can find out in real time if one of our patients from a practice has been admitted or discharged from another hospital. And it brought this huge awareness to the patients that, okay, they know they're going to call. I can expect a call when I'm discharged from any hospital in the state from our practice. So I better be prepared to tell them what happened, how my medications were changed or altered, and what the treatment plan is for me. And so the goal really is to create that value, to show the patients where you don't have to be in an office, you don't have to be at the hospital. We want to engage with you on your terms, so to speak.
Great. So, Lanie, let's hear a little bit about EMHS. Talk to us about the history there, how you got involved in the Accountable Care Organization program, and then tell us a little bit about how you frame patient engagement.
Sure. So we were one of 17 beacon communities across the country, which brought together competing healthcare organizations in the Bangor region. And we learned over our 3-year grant that we can improve the quality of life of chronic disease patients through care coordination. And that was the impetus to us becoming a Pioneer ACO. And now we are 56 primary care practices with 350 providers across 2/3 of the state of Maine. Now, a lot of those are EMHS members, but some of them are non-members who are a part of our ACO. And what we've seen is true engagement happens not when a provider engages with the patient, but when everybody who touches the patient feels like they're a caregiver. So whether you're the receptionist who answers the phone, or the scheduler, or the MA who walks you back to take your blood pressure, everyone has an opportunity at that point to engage with that patient to find out what they need at that moment in time to make a difference in their life. And by having a full-time communications person like myself, we can help them come up with messaging so they understand their role in patient care. And I don't think at any time in the past everyone felt empowered to be a caregiver. And now we're empowering everybody in the office to feel like they're a part of that patient's experience. And that's made a big difference for our patients. And not only that, but we're enveloping all of our communities. So the area agencies on aging, the public health, and all of the communities that our primary care practices are, they're very aware of what we're doing because a lot of their consumers are our patients. So if they know what we're about as a system and how we're trying to improve care and quality, they can help reinforce that with the consumers that reach out to them with questions. So we've made it not about primary care or hospital care, but really about building healthy communities.
So patient engagement is central to the ACO. How did you set up the conversation around, well, what is it? Since there's obviously no pat definition per se, there are guidance and guidelines. How did you approach it?
What we did was actually ask patients, what does it mean to you? We developed a patient advisory council that wasn't primary care or an organization specific. It was a community-wide specific approach, and we asked patients, what does this mean to you? If you're going to receive this kind of care, what would you want to know about it? Who do you want to know about that from? So we asked patients. I think for years, patient engagement and patient advisory councils were made up of, retired doctors and retired nurses, retired people from healthcare. And we asked the average person, we started a patient advisory group. The youngest member was 22, the oldest one was 99, living on her own. We asked them, what do you want to know? When we build a patient portal, what do you want it to say? How do you want it to look? So we asked the people who we're trying to care for, how do you want to receive care? It opened up a whole new opportunity for us, and we started telling stories. And the more stories you tell, the more people can relate, like, oh my gosh, that could be my Uncle Joe, or that's Mary that I see at the grocery store. So it really made care personal, because this isn't someone from another state calling you to help you get better. This is someone in your community that actually cares about you.
Listen to your audience. What a concept.
Yeah.
For those who may not get the Pioneer, talk a little bit about what does that mean exactly?
What do you mean?
Well, in terms of, you're a Pioneer class in the ACO program. So typically, the Pioneers are the more mature organizations in terms of perhaps managing risk. Is that fair characterization?
Well, it is, and I think that we're still trying to figure that out right now. I mean, I think a lot of us that are a part of these ACOs, I always term it, the horse and the cart are racing each other, and the horse hasn't pulled out front yet, so we're still learning as we go. So every day things are changing. We now have transitions of care nurses, for example, who are embedded in our hospitals, who know when one of our patients show up there, they work directly with the the inpatient care managers and the primary care coordinators. And so all of these things they're changing almost on a daily basis. In fact, when I get back to Maine on Monday, pretty sure I'm going to have a whole new set of things I need to figure out how to communicate to our practices.
Great, thanks. So Libby,
yes,
you're with Athena.
I am.
You're not, as I know, stewarding an ACO per se. You're in a vendor, perhaps management services relationship. Vendor?
Yeah. Service providers.
Okay, so talk about, what's
Sure.
Athena's take on patient engagement?
So Athena's take is that we're looking to build the national information health backbone. And the key word there is information. And we provide services that enable ACOs and healthcare and organizations in general with the ability to translate that information into insight. An insight that can be used at the point of care to really identify care gaps and manage your patient populations. And we take that a step farther and have additional services. I was thrilled to hear that both Lanie and Colin are using patient portals. It's also a significant component of the services that we provide as well to really engage patients in their care. And one of the things that we think a lot about is the sanctity of the relationship between a patient and their provider and having that really patient-centric relationship. And we do that through all kinds of different tools that we make sure are patient-friendly. We have not necessarily a patient panel, but we have different ways that we ensure that all of the tools and the services that we provide to patients really engage them in their care. An example of that, excuse me, is where a provider might be treating a patient with high blood pressure, and they have opportunities to establish what we call ticklers, or where patients should be coming back into the office on a regular basis as determined by their provider, letting them know different automated messaging that reaches out to the patient, whether it's a text message, an email, a phone call. It's really their choice how they'd like to be contacted, coming back into the office. And we also believe that the provider, and to a large extent the care team, are really the key to engaging patient and understanding the ways that they can be activated in their care. So it's the provider making sure the patient knows about the portal. We've actually had employees of Athena go out and do site visits and be sitting in receptions and talking to patients and saying, oh, so what do you think about the patient portal? What patient portal? So that makes me crazy. So I have a lot of opportunity there, but it's having the provider then making sure the patient knows about it, making sure that they're delivering to the patient information so they really understand the condition that they're dealing with, and engaging with them through the portal where they can reach out if they're having a question about a medication that they might be taking that's not working, or just having questions in general about, I'm feeling this way, should I come back in to see you? So we really feel as though there's a robust set of tools that can be used to really help a provider engage with their patients.
So would it be fair to characterize Athena's principal or original market as being the physician market?
Yes, and the foundation of the organization was in revenue cycle management, and we now have also our clinicals product, our EHR. We have our Athena Communicator product, which is our patient engagement platform, and we also recently launched Athena Clarity, which is our population health services.
So how have you engaged the docs? What kind of feedback are you getting, and what's your pulse of what they're bullish, bearish? Where's the attitude?
That's a great question. So I'm just fresh out of a physician advisory board that we had a couple weeks ago, and in particular, we talked about patient engagement. And everyone raised their hand and was incredibly excited about the concept, but when we asked them to talk more about what does that really mean, crickets. And so I think everyone is really, they embody and feel like advocates about patient engagement, but they haven't yet tied it together. And you touched upon earlier the eHealth Collaboratives framework. And so we're exploring ways where we can take that and try to really infuse it and espouse the values of that framework with our providers on our services.
So talk a little bit, similar question, the huddle around defining patient engagement. We'll talk about the process at Athena. What'd you go through?
Well, we have explored things like the Health Collaboratives framework, talking to our physician advisory board, and talking to patients, and really understanding the types of things that they feel would not just engage, but we also feel the significant part is activating. So it's one thing to make patients aware of the fact that they should be thinking about their health care, but it's another thing to actually activate them where they're taking actions related to their health care. Lanie was sharing with us earlier that she is the super athlete of the group. Colin apparently has a dusty treadmill. A bunch of us are wearing Fitbits at Athena Health. And so, there's different levels of where consumers are today with engaging in their care, but we're looking at exploring ways to really help providers establish the engagement, but also find ways to directly target patients themselves, because there's a lot that we can do to help our clients, our providers, to better engage with their patients.
That's great. So Colin, back to you. The title of the segment is patient engagement in an ACO world. Talk a little bit about the ACO world that you find yourself in. Are you a sole ACO in the market? Are you competing against others? Where are you at in the class?
So there are a few, there's about 10 ACOs in Maryland. There are 2 that have a hospital partner as part of their ACO. And there are, the other 8 are mostly primary care or multi-specialty groups. We're located in Towson, Maryland, northern Baltimore city area. We're just outside the city. So we're in an area that's dominated by large academic medical centers and in Johns Hopkins and the University of Maryland, as well as MedStar Health, who has a large presence both here in DC and in Baltimore. So there's still a lot of hospital-driven activity. We're a small community hospital that has a large multi-specialty provider group, and we started thinking, and this is in conjunction with our board saying, we really need to be providing the care we want for our own loved ones. That's the test. Everybody calls it the mom test, but that became our vision. And so we set out to do this patient-centered medical home, and then we wanted to get in on the ACO activity because it seemed like the natural progression. So we are concentrating on things that from an ACO perspective are very good, but if you were part of a health system that relied on hospital revenue to pay those bills, you would be have one foot in 2 different rowboats. But we find the value for the patient, and we get the feedback from the providers too that say, this is why I went to medical school. I want to see patients in this kind of environment. This is beneficial to me. We get providers that call us and they say, at first when you talked about extending your hours or opening up on Saturdays, I wasn't really sure that that's what I wanted to do, but I was able to stop 3 of my patients from needing to go to the emergency department this Saturday because we were available to them. So that's the kind of activity that in our ACO we're very excited about. And part of that too is there's this, the engagement on the provider side is all about information. So it's not top of mind. They want to be engaging with patients, and patients want to be engaged, but they don't know what they don't know. And with the information in electronic health records, with the HIE, we're starting to bubble that information up so people can now concentrate on the things that bring value to the system. And just a quick story, we are in this encounter notification system. We know if a patient goes to Johns Hopkins or to GBMC, our primary care practice will be notified in real time. Prior to that, we had a patient that we discharged from GBMC that we offered transition care activity to. So the patient said, sure, that would be great. We discharged the patient on Monday. He said, call me tomorrow. So we called Mr. Jones, and he says, hey, I'm a little tied up. Why don't you guys call me back on Wednesday? So we call him back on Wednesday, and Mrs. Jones answers the phone, and she said, well, he's not here. He was admitted to another hospital yesterday morning. So we were talking to Mr. Jones in a hospital bed, and he didn't share with us that he was in the hospital bed. So now we get that notification, and we know, that the idea is not to be big brother. The idea is that when Mr. Jones is ready to be discharged, we can have him into the practice. We can save time for him to have his medications reconciled, or down the road, we can meet him at home and help him with home health services.
No big brother, just care management, right?
Just value to help him.
There you go. So the other side is now Maryland is somewhat unique on the hospital pricing side.
Yeah.
And these are not HMOs. You don't lock them down with gatekeepers. The patient can vote with their feet.
That's right.
How does that put a premium for you on the patient engagement implementation?
Yeah, so Maryland has the lone Medicare waiver. So there's a Health Services Cost Review Commission that sets hospital rates in an all-payer system. So United and the Blues and Medicare all pay the same for inpatient services. And the rates on the inpatient side are factors of the costs of providing the care at each of those locations. So if you are in an urban setting with high-cost indigent care, your hospital rates are going to be higher than where we're located in Towson, where there isn't as much indigent care. Maybe the academic mission, there's some additional resources in your rates for that. So if you take just a pneumonia patient, assuming that quality is the same, that if you had that patient come to GBMC, the hospital, that might be worth $10,000 in cost to your ACO. If that patient voted with their feet and went to Johns Hopkins, that might be a $14,000 or $15,000 admission for the same service. So for us in the ACO, it's really important that we are showing the value to the patient, that they understand when I go to my primary care office, good things happen. So if I'm not feeling well at 5 o'clock, I can still be seen at 7 o'clock. I don't have to make a choice about an emergency department. Or if I'm not feeling well on Saturday morning, I can be seen by my PCP, or at least call them and make a determination about tweaking a medication. So I'm not making that choice that could have a financial impact.
Before I go to Lanie, one more question. So what do you see as the tools to really optimize this patient relationship?
Well, I think it's a combination of things. It's a combination of education and higher level communication. So, you know, earlier the question about, are you using your inhaler? Show me how you're doing it. Simple things like falls risk isn't a question anymore about, did you see the patient stand up and sit down when you're taking the vitals? It's, have you had any falls? Do you need any assistance with ambulation? So that we're changing the dialogue. Mm-hmm. We are giving them opportunities to communicate, to close feedback loops, so the portal is an active part of that. We have, like our colleagues, we have focus groups and patient advisory panels where we're trying to hear from them what would be helpful. There's a lot of technology out there. Is an app the best way to you know, communicate with the 70-year-old patient, or do they prefer text messaging or the portal or a phone call? So there's a lot of different things that we have to pull together from the ACO perspective to really maximize that activation and engagement.
Great. So Lanie, tell us about your world. Talk about your marketplace and what some of the competitive dynamics are in terms of your organization.
Well, like I said, we cover 2/3 of the state of Maine, and our healthcare system has 7 hospitals, 1 tertiary care. But in these other communities, there are other competing hospitals, and we've managed to forge relationships with them, and their providers are a part of our population health meetings. So we're all driving towards the same quality. So really, we're not trying to develop cookie cutter care. It's still very personalized based on the community it serves and the primary care practice that is there. I think what we're focusing on really is relationship care. All of this work can't be on the shoulders of the provider. They're already working 14, 16 hours a day. At some point, those providers need to get a quality of life back so they don't burn out. And I think we're trying to develop a system where providers have support and they're not feeling all of this as their responsibility. Patient engagement is all of our responsibility, and it's really developing tools so that everybody feels their significant importance in that relationship with those patients that walk through their doors.
How do you, that's music to the ears of the people who are going to be principally affected by this, because so much of this appears to be piling on, more stuff, changes in workflow, you know, yada, yada, yada. So how are you making it user-friendly versus a piling-on situation?
So really, it's developing relationships with all of these primary care practices. I'm one person, but I know the primary care. I know all the care coordinators throughout all of our entire system, and so I think it's having someone who's going to take on the responsibility of helping people learn how to communicate. Communication isn't something we all do naturally. Some people are more empathetic and compassionate than others, but I think we can all learn it. And I think it's really investing in somebody or a department to help your organization teach those that are going to be responsible for caregiving how to listen to the patients. Some of our most effective care coordinators, which are our nurses, are effective because their patients trust them. And you trust them because you believe in them. You called one time and asked for help, and they responded to you quickly and got you what you needed. So I think that organizations can't just, support the providers and the nurses. They need to support someone who's going to help them learn how to communicate with their patients effectively and the community itself. And I don't know that that's always been, the first thing that you're willing to pay for. Someone asked a question earlier, is ONC looking at ways to support offices to engage patients? Well, no, I don't know that any of my cost center falls under being reimbursed. However, communications people are probably your key to success. because not all providers can communicate, not all nurses can communicate, not all MAs can communicate, but there are little gems all over the place that we can learn from and help broaden that across our entire system.
So how are you approaching that cultural shift? Because there's people, process, and technology. And what we're presumably doing is we're moving towards this patient-centric notion,
Right.
which hasn't been necessarily at the core of the mission. It's more provider-centered versus patient-centered. How are you sort of facilitating that cultural shift?
So we hear of wins all the time, and I mentioned storytelling. Storytelling is very powerful because if you incorporate a patient in your story and all of their care team, that kind of breeds success. Because, as someone mentioned earlier, providers are very competitive. If Dr. Mishu is very successful at his practice, and we've told a story about how he listened and got the care that patient needed, that forces other doctors or care teams to think, wow, we can do it better than they can. So it's that storytelling. It's finding those little pockets of success that are happening and sharing them across our system. It teaches people without hitting them over the head with a pan, saying this is how you treat people. And it's constantly reminding them, how would you want your child or mom to be treated when they walk through the door? If you're having a bad day, doesn't mean you have to share that with with the patient that walks in. No one wants to come to the doctor's office. So it's really telling stories and making it very personal. Healthcare is very personal. And while we have all this great technology and QI nurses and all of these people that are running data, those are all necessary things, but patients don't want to know about that. They want to know when they pick up the phone that someone's going to have time for them.
Libby, so where's Athena here in terms of, are you change agents? Are you soldiers in the transformation?
Absolutely, we are. It's funny that Lanie was referring to the storytelling, and we find that that's also very powerful for our clients, which, as an example, we now, and you touched on also like ONC and CMS and some of the things that are coming with meaningful use stage 2, all EHR providers will need to be adopting tools that enable secure messaging. And so through secure messaging via the portal, we now have tools for a patient. A particular example, a patient had sent a message to a provider over the weekend. The provider was on call, was using our Athena's mobile-enabled clinical inbox to be able to see the message from the patient and was be able to immediately respond to them with something that actually was a fairly significant issue that they did need to be seen immediately. They were able to give them the great direction, and the situation was handled properly, but without having been the change agent of building out our mobile tools and providing doctors the ability to be wherever they are, whatever tools they're using, whether they're in the office, whether they're on the go, being able to really continue that relationship with the patients. And patient engagement, we're thinking that it's starting to be a lot more like what most industries use for CRM, customer relationship management. It's about patient relationship management across the care continuum. It's when they're in the office, it's when they're being discharged, it's when they're off on vacation and they need a prescription refill, being able to have those tools that are easily accessible both to the patient and to the provider. But there's another aspect to this that we haven't touched on that Athena thinks a lot about, which is the financial responsibility that patients have in healthcare today. With the growing trend towards more patient and consumer responsibility, we're also looking at ways to really simplify and make the whole payment process much easier for patients, really understanding their bills, understanding their responsibilities, and providing them easy, simple ways to pay their bills, again, from whatever device that they choose to use. So there's the clinical part that's very important with population health, but there's also the financial side and making sure that patients are positioning themselves well and have the tools at their disposal to be able to meet those issues, that side of the equation.
So all healthcare is local. Are you feeling any particular flavoring in the Southeast versus the West versus the North Atlantic corridor? Do you have any sense of, is this, how's this playing out?
So right now, I mean, Athena is established in the Boston area, so we have been a bit of an East Coast company, but we're certainly establishing more and more on our West Coast side of things. And one of the things that's been happening quite a bit is that we have a growing population that are Spanish speaking. And so we've found that in the Southwest in particular, a lot of our clients are really looking to have us extend our solution so that the patient engagement capabilities are not just for our English-speaking patients. And so I think that's one of the major trends that we're seeing right now. But certainly in the Northeast, there's a lot of organizations that are following ACO models in particular, and that's where a lot of our clients using our population health tools exist today.
So, Colin, you used a term that blew my mind, real-time notification of what's happening out there in the care continuum. How'd that happen?
So we have a pretty progressive regional HIE in CRISP, and so they have been connecting hospitals to share ADT data as well as labs, imaging. There are 46 facilities that exchange information. And then what they've done is they've said, okay, let's extend this to long-term care facilities, to primary care offices, because the value is in the exchange is keeping those primary care docs, the quarterbacks, aware of what's happening and where the folks are. So we have the ability when we're notified, and it's only as real time as the person is in there, because it has to be through a secure messaging system right now. But essentially we send a patient panel every month. It gets pinged against the real-time activity. So at 8:52, there could be a hit, and it would send a notification to this inbox, and our care coordinators, our non-clinical care coordinators, monitor this feed every day. And they notify the provider. If it's an emergency department, they notify the provider and they say, you know, what, do you want me to get in touch with the ED doc? Or, you know, fax over medication list. If it's on the discharge side, we'll go ahead and reach out to the patient and begin to schedule that appointment for them. And in some cases, we've been notified, contacted the patient, and scheduled them for a same-day appointment before the home health agency. They may have been discharged with home health needs. Before that home health agency can even contact them to begin that process. So it's been a great tool for us to really sort of help get people back on track. A lot of our readmissions were happening within the first 7 days, and we're trying to push that. We want to have no unnecessary readmissions, but we're trying to push that time period back as far as we can.
So is it all just about the portal, or is there more? And what about patient narrative, and how does that get into the mix?
Yeah, I think, well, every patient and every practice is going to be a little bit different. The dynamics of a population in one practice may skew older, may skew more acute. We may have a younger population that's more healthy. So your needs have to be varied. There's not a one-size-fits-all solution. I think that the technology certainly helps us when they've gotten to the point of consuming that resource, right? But ideally, we're doing something to prevent that from ever happening in the first place. If they get to the emergency department, that's like starting the game in the second quarter. So what we want to do really is to try and work it. So a patient that's been newly diagnosed with a condition, we want to work with them, with the care managers. We want to give them the education that they potentially could need. We want to let them know if they have questions not only about their clinical progression, but anything about the ACO, that here are the ways that they can reach out to us. And then we have forums for them to come back and to tell us, hey, this is what we're feeling from you, and we think this would be a little bit different. We have one scheduled for Tuesday, as a matter of fact, where we're going to sit down and we're going to talk about ways that we might improve upon the medication therapy management for patients that are on, some of our patients are as many as 18 different medications. So we really need to engage them, but it's not a one-size-fits-all by any means.
And where is social in this mix? How are you using it?
We use it more on the hospital side of the equation. So it's a lot more education about, those seasonal things that are coming up. So you might want to be prepared if you have allergies for this type of thing, because we see a lot of asthma cases pick up. And if there's education that we can do and to interact with folks there, we have Twitter, we have Facebook, where people can interact with us that way as well. And we've seen some questions come in through there, but if they're already in a primary care practice, they're generally going through the portal.
Lanie, same question. Is it just about the portal, or is there more?
No, it's not just about the portal, because one tool isn't going to fit everybody. And it's really asking the patients, how do you want to communicate with us? We actually have a 72-hour policy for any of our patients who get discharged from the hospital. They will be called at home within 72 hours, because that's that window of readmission. And we have community care teams who are reaching those patients who we just, for whatever reason, can't help in our primary care practice. So we have social workers who go in the home. In fact, we had a community care team go into this home, and one of the things they were checking, I noticed your smoke detectors don't have any batteries in them. So they went and got those for him and helped the gentleman with his med reconciliation and all of that. Well, 2 days later, he was outside cutting wood or something, and he heard his smoke detector go off. His house almost burned down. So we have community care teams who are making impacts at that kind of personal level. They're going into homes and really changing and giving the providers a 360 view of the family that they never got to see before, that a nurse care coordinator embedded in the practice didn't even get to know. So it's really reaching the patients where they're comfortable being reached, and whether that's telephonically, whether that's face-to-face, whether that's in the home, whether it's through a patient portal. We're trying to figure out what works best for you, and it's really involving the whole community. We're not just about building healthy patient panels. It's about how can we best build healthy communities using the resources that already exist, so we're not creating or recreating things that are already working really well out there. It's bringing everybody into the conversation, and I don't know that that was happening prior to us being a beacon community and now being an ACO.
And can I just add, it's a delicate balance too, because what we've heard is, what I don't like is to get a call from the office, scheduling an appointment, a call from a care coordinator who doesn't know that I just was on the phone with somebody from the practice, a call from the hospital, a call from the transition guide, a call from the specialist. So they're looking for a way to streamline that process, and they just like, there's alert fatigue with CPOE. You don't want to be bombarded every time you're ordering Sudafed for somebody. It's the same thing here. They don't want to be notified 50 different ways if it could be streamlined and could be one meaningful way.
And yet some patients do want to be notified 50 different ways. So it's really documenting how that patient wants to receive their care. And it's also not using, if you tell a patient what we're doing right now, real-time access to your records and all that, they will look at you like, you didn't already have that? They're really astounded, because they really thought that they were the center of their care. They really thought you knew when they were in the hospital. They really thought you knew that they had their immunization at work. And truth be told, we didn't. So it's really having conversations with patients about what we do and don't know about them, and what information we need from them in order to make the picture complete.
So I'm going to ask you a question. I'm going to introduce Ben Schroeder, who hosts the EMHS Zone. Always asks his guests, so what's your favorite app? So in line of that, do you have any particular technology or digital tool that comes top of mind to you as far as adding to that whole improvement?
Well, a lot of patients spend a lot of time in waiting rooms if they're chronic disease patients or whatever, and they all have these great television screens in there. And we are finding that we are getting a lot of utilization out of that by having messages on there, including personal stories with videos that we've created. I don't know that we've come to the whole world of app yet, because we all can't agree on what to agree on. And in all honesty, in our patient advisory group, asking the 20-somethings on your patient portal, do you want Facebook and all of those things as part of your page? They said, absolutely not. So I think that we haven't quite figured out what apps are the ones that we want and which ones are going to help us promote the kind of care we want to provide. So that's why those vendors out there are really kind of helpful right now. But the screens in all the waiting rooms, what an untapped resource. You can share with patients, be a part of a patient advisory council. What's your opinion about this? Those are unutilized, and people have nothing but time on their hands when they're sitting there. So that right now is what we're finding to be very helpful in educating patients and also educating ourselves about what they need.
So we're often advised, go to where your customer is, and many of our, quote, customers are out there on social media. What kind of commitment has your system made to social?
Yeah. We're starting to build that right now. It's who has time for it. With our Bangor Beacon community, we had almost, 19,000 followers that basically are probably wondering what we're up to now, because we had one person dedicated to Facebook, social media, Twitter and things like that. I personally don't have time to sit on the computer all day because I have to have face-to-face relationships with people in order to find the bright spots that are taking place. So as a system, we're trying to develop how we're going to do that and how we can communicate across our entire region and the country what's happening. But I don't know. It's one of those things that patient engagement, people talked about it for years, meaningful use. And now we're actually seeing what that means. I think we're trying to figure out what social media means and how we can use it to best educate our patients as well as get important feedback from them.
So Libby, have you figured out a way to add value here in terms of vetting what's out there and maybe positioning it to facilitate the workflow?
Yeah, absolutely. I mean, you couldn't have asked a better question. So Athena, we can't do it all. We have limited resources. We have a lot of great, amazing people at Athena, but there's tons to be done. And we recently introduced our More Disruption Please program. There's actually some vendors here today that are part of that program, and they're allowing us to extend into areas like the waiting room. The Athena Communicator product has a way for patients to be able to check in online. Those of you who flew here, you probably checked in online before your appointment, before your flight, and maybe updated the seat that you had of preference. And we have those types of capabilities, so a patient can be at their home at the time that's convenient for them to check in for their appointment online, update their demographic information, perhaps adding their next of kin, and while they're at home with their medications, update the valid information about the medications that they're taking and letting their provider know about things that maybe they're no longer taking. So when they arrive for that appointment, the information is there during the intake process. And one of the vendors here today is actually going to be engaging with our solutions to provide those capabilities in a kiosk environment. Additionally, we're working through the MDP program, we're working with self-scheduling vendors. So a favorite app, one of them might be iTriage. So we're opening up the ability for folks that might be using the iTriage application on their smartphones, where they're out and about, all of a sudden have a terrible earache and feel like they need to be seen immediately. We'll be able to identify the condition, look at providers in their local area, and then be able to self-schedule an appointment directly through an Athena provider.
Great. So before we close out, are there any last thoughts from the panel? If not,
I guess the one last thing I would say about, is it all about the patient portal? It's not. I mean, it's important that there are other ways that we engage with patients. And it needs to be according to their preferences. And there may be families where they don't want you calling them after 7 o'clock at night because the kids have gone to bed. Making sure that the tools that you provide are really communicating to the parent, if it's the caregiver or the patient themselves, the way that they've asked you to communicate with them about their care.
I did have a last thought. We may do all of that right, and the patient still might not be interested in doing it. But it doesn't mean that we're not going to keep trying and attempt to help them through wellness.
So we'll open it up for questions in the last 7 minutes or such. But where are you on ACOs? Bullish, bearish?
Oh, they're terrible. No, of course.
Will they work?
Yeah, I think so. I think they will. So the question is about, really about around the shared savings arrangements and taking that risk and being able to understand your population so that you're not getting yourself into a situation where the patient can walk. They're not in an exclusive arrangement. But all of the data that we've seen coming back from Medicare about what we're doing, it's having a huge impact. All of the patient satisfaction scores within that office are having a huge impact. So we're very excited about being in the ACO.
Lanie?
We're excited. I mean, we're seeing real change take place. So I think we're just, we're at the tip of the iceberg right now.
Great. Libby?
We're incredibly optimistic. We just think that more information needs to be made available so that providers really have all the information they need to care for their patients.
Great, thanks. So we have about 6 minutes remaining. If there's anybody in the audience who has a question or two, just go to the mic and we'll have the experts respond.
Yes, my name is Eva Powell and I work for athenahealth. And on the topic of communication, I was wondering if any of you have information you can share about how you've specifically implemented two interventions that seem to me to be critical to that. One would be the patient activation measure and questions that really open up a world of information that has really never before been understood by healthcare about where a patient is and their ability to engage in their care. And then on the physician side, shared decision making, which is an actual process that requires skill and not just a conversation, which is a good place to start, but that a true shared decision making process requires skill that I think many providers could use some training on. And so I'm just wondering if either of you have implemented either of those really specific interventions, and if so, how have you done that and how has it gone?
Who wants to take that?
Well, we were talking about that, the Hillenbrand patient activation measure backstage here. So in our journey, we're not quite there yet. We're just at that point where this is something that we want to try and implement. And figure out how we can best understand those patients' readiness. On the provider side, it's not specific, but we're doing other things within CMMI grants around PDSAs every month to try and get providers to understand where we have opportunities to engage the patient more in deciding about certain things. Some places we do it better. We have a large geriatric practice where there obviously conversations about palliative care and ultimately hospice care are more topical to them, but it hasn't trickled back into the primary care, internal medicine, family practice yet.
And we have monthly population health meetings where our senior medical director, who is also a practicing physician in one of our internal medicine practices, and the care coordinator, they will all go to a practice and they'll review specific cases and talk about areas of opportunity that they're seeing based on the data, and coming up with ways that they can meet the needs of their patients. And those seem to be going well. We just started implementing those within the last 2 months, but so far they've been really well received.
Anybody else?
Right here, Mike Mitchell with Bravo Wellness. This is directed probably more so to Libby from your comments that you've made. What is Athena's position, or what is their outlook on financial incentives that are being used in terms of bringing more accountability down to that patient level for taking an active role in closing gaps in care and taking an active role in following the clinical directives, especially on with the recent released final wellness rules that came down from the DOL and HHS. Any comment relative to what's going on at the federal level?
Sure. So certainly we want to be able to support our providers to be able to attain all the incentives that they're applicable for, and we are providing them many tools to be able to do that through our population health solutions, Athena Clarity in particular. If it's not something you've had an opportunity to learn about, I would encourage you to do so. In addition, through our Athena clinical solution, we support many of the pay-for-performance programs, and as new ones come out, we're adding them into our solutions as quickly as possible.
Any others?
Yes, Charlie Abedian with Video Call. We're introducing the MedX Spot platform for lower cost outpatient services. One thing I haven't heard from any of the panelists is how are you going to deal with the increased volume of people looking for health services? McKinsey says that outpatient services is one of the highest growth costs that we have in the healthcare arena. We've got physicians that are going to become more scarce, and we got 30+ million uninsured that are going to be looking for primary health care. How are ACOs dealing with that, or trying to find a solution for that?
Well, for EMHS, we have a lot of mid-levels, so we have a lot of nurse practitioners and family practitioners who have the oversight of a provider in their practice and PAs. And so the MDs and the DOs are doing a lot of the complex care patients that have, the more complexity in their case, in their care. And that seems to be working well for us. And also we're having everybody kind of work up to the extent of their license, which means by the time the doctor sees you, you've had all of the other little things taken place so that you can actually grow your panel size. We're just starting down that road, so I don't have whether it's going to work or not, but everyone seems to be excited about it. When you go into the primary care practices, A lot of the MAs are pretty excited about the fact that, they're going to be able to start providing more care. The nurses are excited because it means they'll actually get to start doing the stuff they went to nursing school for. And the doctors are excited because they are going to actually start working on the cases that they want to actually know that they can impact. So I'm optimistic that it'll work, and that's going to be our approach, I think, unless someone has some solution to get a whole bunch of people through medical school in the next decade.
We're constrained. So we're constrained with the providers that we have. We need more, and we're constrained with physical space. So even if we could find someone, it would be difficult to without completely re-engineering that 15-minute interaction with the provider. So we're looking to repoint our residency program so that we can create sort of a farm team, if you will. But our market is very competitive for primary care. There aren't a lot that are independent. So yeah, it's going to be a big challenge for us.
And just to add to that, our philosophy is exactly what Lanie said, is enabling our providers, or all of our providers, to be able to operate at the top of their license. So how can we move work that intake folks maybe can now push down to patients? How can intake folks be now activating patients in their care through the things that they can do, and then having our providers really be focused on the things that are really clinically dense that they really need to be able to contribute around.
And one thing that's been really kind of exciting is this empowerment that I've been talking about. We've had nurses who are now going to nurse practitioner school. So people are going, wow, I can do more and do better, and we have MAs who are going to become nurses. So in an ideal world, that's what will happen. Someone will come into a primary care and be so excited about the work that they're doing, they're just going to want to do more and be more. So it's supporting their education as well, I think, will be key to the success of it.
I think we're out of time, or do we have any last? David?
Okay. Yes, you mentioned about CRMs and also the airline industry with the kiosks, and we know that wearable computing, the Israeli Army and now the U.S. Army adopted many things. They're the most advanced with wearable technology, sensor-based technologies. Lean came from the auto industry. A lot of other industries have a lot of technology solutions and organizational solutions also that healthcare is just getting around to. And healthcare is very siloed. And there's a not invented here context to that as well. As institutional players, what are you all seeing, and what are you looking for that maybe isn't in healthcare, but are solutions to many of the engagement problems from other industries or academia, organization, military?
I would put the financial industry in there too.
Definitely
Absolutely,
finance.
yep.
Exactly.
Well, from a product perspective, certainly we take our cues from industries, and healthcare has been a laggard. It's astounding that it's taken this long to have a patient portal be something that's common for most patients today, or when they know about it. And we are certainly introducing things that are as consumer friendly as possible. I think that's one of the things that in the early days of the introduction of some of healthcare IT solutions, we thought that we needed to do it differently because healthcare is different. But our philosophy is that consumers are used to using things a certain way. They're used to using Amazon. So when a patient is paying their bill, they should be able to save their credit card on file, so when they go in to pay their bill next time, the credit card's already there. That's just one example, but we certainly think that we should be looking to the cues that consumers are already used to using.
And I have to echo what she says.
Great. Well, that's going to have to be the last word. Thanks for coming.
Ladies and gentlemen, lunch will now be served in the Monticello room.